Perfect. So the first thing we're going to talk about is the spine. So what are we going to focus on? We really want to focus on the mechanism of injury, where the injury occurred, and some of our differentiations in SCIs. We also really want to review and reiterate neurogenic shock. So that's going to be the focus. So essentially, why are we concerned with spinal cord injuries? One, we're concerned because it can really lead to severe loss of function and paralysis, but we're also concerned where along the vertebrae that this happened. Any injury above T6, those patients are at increased risk for neurogenic shock. Additionally, the higher up on the spinal cord, the more severe the injury is going to be. So really our primary spinal cord injury, that is the initial disruption of the spinal cord. That is the impact, whether it was from a motor vehicle accident, a fall, whatever the case may be, that's your primary injury. Now, there are a couple different types of secondary injuries as well, but I really want to talk about spinal shock. Spinal shock is completely normal, okay? Usually when someone has a spinal cord injury, they're not going to start noticing some of these symptoms such as flaccid paralysis. They might have a leaky bladder, sensory issues, till about 48 hours after the onset of the injury, in most cases. So for spinal shock, just know that this is something that's normal for spinal cord injuries. And we want to really help the patient manage these things. What we're really concerned about is neurogenic shock. Neurogenic shock is not normal. It should not be a normal finding in a spinal cord injury, but it can occur. However, it is a medical emergency due to the hemodynamic instability. So I just wanted to kind of separate the two. Spinal shock, think of your spinal cord injury symptoms. That's really what spinal shock is. Now, our secondary injury, this is when we have mass inflammation, edema, and ongoing damage from that initial injury, okay? Also, we really need to understand the concept of autonomic dysreflexia, okay? Where there's a stimulus below the lesion. Now, where's the lesion? That's the break in the spinal cord. So if, let's say, I broke C6, anything below C6 can kind of disrupt my body's nervous system and put my patient in this autonomic dysreflexia. You might also hear it as autonomic hyperreflexia. Okay, but this is also a medical emergency because it causes a massive hypertensive crisis. Okay, my patient's over that 180, they're in the 200s, they're sweating, they're diaphoretic. And they're very, very anxious. And really the only care for this, we have to remove the stimulus, whether it be a folded sheet, a full bladder, a Foley catheter that's not working, whatever the case may be, you have to remove the stimulus and you need to elevate the head of the bed. Additionally, when we're talking about med management, we can give antihypertensives and frequently monitor their blood pressure about every 5 minutes, okay? So that is your autonomic dysreflexia. Again, not the same thing as neurogenic shock. That's why I have them in different colors for you guys. But with neurogenic shock, we also have that hemodynamic instability, but now we're having a drop in blood pressure, a drop in heart rate, and now my patient can't regulate, okay? This puts them at risk for shock, okay? Shock is that drop in blood pressure. So what are we going to do for treatment? When our patient has neurogenic shock, okay, and it should be red, I apologize for that, but when our patient has neurogenic shock, we need to give them drugs that can help increase the heart rate, because remember, they have that bradycardia, hypotension. We need to bring it all up in order to perfuse so that our patient doesn't go into shock, okay? Dopamine is a drug of choice to maintain MAP, specifically highlight star circle methylprednisone. This helps prevent that secondary injury because we know secondary injuries occur due to that mass inflammatory process, mass inflammation, mass metabolites. So what can we do? We can give them some methylprednisone to kind of suppress the immune response, suppress that inflammatory response, okay? We can also give them some PPIs for gastric ulcers. That's pretty common as well. As nurses, we really want to make sure that we follow our airway breathing circulation approach, okay? The first thing that's always done is we always immobilize the backboard with head, brace, spine. Additionally, after we've kind of stabilized, we want to maintain that airway, breathing, and that circulation, and monitor their LOC. While they're still in that back brace, head brace, etc., we need to get a spine CT and an MRI. Okay. And then the rest are just preventing complications of being bedbound. You have spinal cord injury, these patients are probably going to be in bed, not moving a lot. We need to prevent pneumonia. We need to prevent a couple other things, okay? And really get them connected with physical rehab, okay? So I'd really, really focus on your neurogenic shock, your autonomic dysreflexia, and how we're going to manage those, okay? Those are some injuries that we really need to talk about. What's up, Ray?
Hi, quick question, just so I know whenever I'm approaching it on the test.
Mm-hmm.
Let's say you're giving a patient who has like neurogenic shock. What would be like your number one priority? I know it will be like ABCs, maintain the airway. What would be kind of like your like from what you just listed, like your number
Mm-hmm.
one, your number two, and so forth.
Yeah,
Whenever it comes to
absolutely. So I'm going to hop back a slide. Neurogenic shock. See, we have this hemodynamic instability, okay? So it's not necessarily an issue with airway. It's not necessarily a breathing issue either. It's a circulation issue, okay? They have this hypotension, bradycardia. That drop in circulating blood pressure leads to a drop in circulating oxygen. So although you would originally think like, oh, secure the airway is fine in this case. We need to bring up their blood pressure. So we're perfusing their organs, we're perfusing everything, and we're not going into shock, which we'll learn about much later on. But our main concern is that drop in heart rate, that drop in blood pressure. Okay. If I give my patient oxygen, is that really going to help the drop in heart rate, drop in BP? No, it's not. So we need to get those up.
Thank you.
No problem. So I have a couple examples of spinal cord mechanism of injury. It's not super pertinent to memorize every single type, but just know that when we're getting a detailed history, we need to know the mechanism of action, because we might originally see a spinal cord injury, but we have to ask what the mechanism of action was. What if they were hit? What if they were beaten? Etc. Are there any other internal bleeding? So as much as we want to kind of focus on that spinal cord injury, we have to know the mechanism of action, okay? It's just very, very important, because we might need to treat a couple other things in addition to that spinal cord injury. So I have a practice question for you guys. A client with a history of a spinal cord injury reports a severe headache and blurred vision. Upon assessment, the nurse notes the following: hypertension, bradycardia, and a flushed face. Which intervention should the nurse implement first? So I want you guys to do two things for me. Number one, what is this patient experiencing? And number two, what should we do first? Okay, so it's kind of a two-parter, but what do you think is going on right now, and what intervention do we need to do first? What do we think's happening? Okay, so it's not the ICP. Yes, it is our autonomic dysreflexia, and we need to empty the bladder. Okay. I saw someone put ICP. ICP, we see when someone has an increased intracranial pressure, that's when we have that Cushing's triad, which is a which you could think, because you see those changes in vital signs, but we're missing that widened pulse pressure. Additionally, we also know my patient has a history of an SCI. So when they have a spinal cord injury, we need to be thinking along the lines of spinal cord injury. So the correct answer is yes, this is autonomic dysreflexia. We know that a stimulus below the lesion is causing hypertension, bradycardia, and a flushed face. What do? We have to remove the stimulus. Now, if this was select all that apply, and B had said elevate the head of the bed, that would have been great. We elevate, we don't lower the head of the bed, okay? But very, very good job, okay? This helps us differentiate neurogenic shock versus autonomic dysreflexia. When you have AD, that's when we're kind of increased. We're up, 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 up. When we have neurogenic shock, we're down. You can kind of remember that is shock is just a big fancy word for drop in blood pressure. Okay, so that's how you can kind of relate the two. But very good job, guys. Now we're going to talk about the brain, and now we're going to talk about that ICP and all of that fine stuff. So first thing we're going to talk about is our TIA. Okay, this is a stroke of the brain. Well, sort of. So essentially, this is different from a stroke. This is a mini stroke, okay? Temporary stroke. It is reversible. That's the only thing that differentiates this. The most common cause we're going to review risk factors, and why are we concerned. So, like I said, TIA, this is reversible. What is the number one cause? A blockage in our coronary artery. Our carotid artery. Remember we talked a long time ago about coronary artery disease? Well, just think of it's the same concept. Instead of having a blockage in my coronary arteries, I'm having a blockage in my carotid. What does the carotid do? It supplies blood to the brain. So if you really like the heart and you remember a lot about the heart, it's kind of the same thing as that unstable angina, if you can kind of relate the two, where it's just temporary, but we have a blockage that's causing a temporary disruption in blood flow. So we'll see these usual signs and symptoms of a stroke, but they're going to resolve, okay? Like I said, atherosclerosis, coronary artery disease, all of that is a really big risk factor, okay? But these do resolve. So what are we going to do? We know it's usually caused by hypertension, a diet high in cholesterol. We're going to teach kind of managing your diet, managing your BP, managing all of that, giving them antiplatelets. Again, if you can remember the heart, it's like very, very, very similar. And if you can relate the two, it's going to benefit you. Okay. But why are we concerned for a TIA? It's a warning sign to a stroke. Okay. So we really need to teach our patient to kind of manage their BP, manage all of that, and really do a stroke risk assessment, which I have kind of listed under the assess stroke risk. But really a lot of it's going to be blood pressure management, lifestyle changes, etc. Okay, because it is reversible. We can implement healthy lifestyle changes. Now, a stroke, this is, again, more of a medical emergency. This is very, very severe. So we're going to review the different types of strokes and really how they're treated differently. So we have multiple different kinds of strokes. You can group them into two categories and then some subcategories. So we have an ischemic and a hemorrhagic. Just look at the words. Ischemic, think lack of oxygen. How do we have lack of oxygen to an area? Usually an obstruction, blood clot, it can be anything. So you can break that into a thrombotic stroke or an embolic stroke. When we think of thrombotic stroke, that is atherosclerosis directly on those carotids or on those arteries, like direct. An embolus, remember, an embolus is a thrombus on the move. So usually this thrombus originated elsewhere in the body caused by AFib. This clot travels all the way up and it gets stuck in the brain, okay? That's how you can kind of split the two. And then we have our hemorrhagic stroke. This is when a blood vessel bleeds into that space. You can have multiple different kinds, so I would just review your ICH and your SH, okay? Really, they'll have lots of different signs and symptoms. It's not pertinent to memorize every single sign and symptom, but I would memorize your FAST acronym. Your face, have them smile, have them raise their arms up, have them speak, and really know what time all of this is occurring. That's going to be really important in assessing a patient with a stroke. Okay. What are we mainly concerned about? We're also concerned about seizures and increased intracranial pressure. And as you'll come to find out, if at any point we have an increase in intracranial pressure, puts the patient at risk for seizures. It's a really, really big problem. Okay, so what do? We have to get a non-contrast CT to look for the hemorrhage. Ideally, we want this within 45 minutes they get in the door, okay? The reason we're looking for a hemorrhage is we need to identify, is there a brain bleed or not? That's going to dictate treatment, okay? So what is this treatment? Well, if you have any of those aneurysms, you can do a clipping or a coiling. But remember, we get a non-contrast CT to check for brain bleeds. That's going to dictate whether or not we can use fibrinolytic therapy. Fibrinolytic therapy helps us break up clots. Those are our clot busters. However, they help break down clots by increasing blood flow and kind of decreasing our clotting factors and all of that fun stuff. So if my patient has a hemorrhagic stroke or they're bleeding anywhere else in the body, I can't give them fibrinolytics because it's going to cause a massive bleed where they already have a bleed. That's why we get that CT scan. Okay. So fibrinolytics are absolutely contraindicated in a hemorrhagic stroke or if my patient has a bleed elsewhere in the body. Remember I talked about mechanism of injury? Well, what if they're bleeding? What if they had let's say they had a ischemic stroke and then they fell and they're severely bleeding? Well, they might not be a candidate for TPA therapy because, again, they have a bleed. So that's the concept of fibrinolytics and bleeds. Okay. ABCS is a great, easy way to educate your patients. So I would just review that. And really, I want you guys to star their blood pressure. So I know we always teach blood pressure management. However, when someone had a stroke, they lost oxygen to the brain. So when they're healing, I want to increase their blood pressure to increase their cerebral perfusion, okay, just to help regain some of that function that they might have lost. So this is the only time I would say we're going to keep their blood pressure a little bit elevated. Not a hypertensive crisis by any means, but of 150 to 100. Multiple different types of post-stroke deficits. I would just go ahead and review some of those on your own time. Specifically, dysphagia is our number one concern because then that gives me an airway breathing issue, okay? If they can't swallow, they can choke, they can aspirate, not fun. If my patient had a stroke, I need to keep them NPO. I have to keep them NPO because I need speech therapy to do a swallow study. I need to know if they can swallow or not. Are they safe to swallow their meds? Are they safe to swallow water? Because we really don't want to compromise their airway and their breathing. This is just a drug card for your ATP medication. Again, a couple different things you need to keep in mind. It has to be used within 3 hours. We are absolutely contraindicated in brain bleeds, anticoagulation therapy, active bleed, etc. Okay, so just review those. So now we're going to talk about a TBI, a traumatic brain injury. We're going to review the main concern, differences between some of the hematomas, and signs and symptoms and treatment of increased intracranial pressure. Okay. So TBI is just damage to the brain. We've all kind of heard of it in football, especially. Those patients or those players are at risk for CTE, etc. Symptoms can range from mild, moderate to severe, etc. Again, I want you to focus on the injury and what goes beyond the injury. So the injury is one thing. Remember our coop, contra coop, that's that primary injury. Am I concerned in that moment? No. I'm concerned for the future because of that increased ICP. Medical treatment, specific to a TBI, it ranges. I will teach you guys the medication, the medical treatment for increased ICP in a few slides, but just know that these patients might have to have their ICP monitored through an external catheter through the brain, okay? After the injury, we want to follow head injury protocol: no running, no sports, no baths. We don't want you falling asleep in the tub, etc. Our main goal: prevent second impact syndrome and really let the brain heal. When we're talking about our hematomas, this is a brain bleed. These are really common in TBIs. So I would just kind of review the signs and symptoms that kind of help separate subdural versus our uh, our epidural hematomas. I just taught about TB and subdermal injections, so I apologize if my speech is a little bit off. But just what I want you guys to know, excuse me, about our subdural hematoma is that this has a really high mortality rate because it doesn't really present with a lot of signs and symptoms. So these patients might not know to get help. So just keep that in mind. They're not going to present with too many symptoms, and symptoms might take months to develop. So this is why it has a little bit of a higher mortality rate than our epidural hematomas. These ones are more severe, but these patients can get treatment because they know to get treatment. So with an epidural hematoma, they're going to have a brief loss of consciousness, a tiny little lucid interval, and then you'll just see their LOC just deteriorate. So if you're working in the ED and a patient comes in with a head wound, head injury, you'll see those nurses asking multiple times every few minutes, where are you? What's your name? What happened? Where are you? What's your name? What happened? It's because we're trying to see what's going on. Okay. So now we get to talk about my personal favorite topic: increased intracranial pressure. Okay. The brain, it's a closed box. There's no room to give. Meaning, if I break my arm is going to swell. But my arm can swell, and that is fine because I have skin, I have muscles that can expand. The brain, not so much. It's stuck in the skull. So at first, if there's any sort of swelling, whether it be from a TBI, whether it be from a brain bleed, or even a tumor, okay, that's going to cause an increase in pressure. At first, the fluid might displace, but there's not a lot of fluid up there anyway, so we really need to get the swelling under control. Okay, so what happens with this closed box? As things swell and swell and swell, things start to get crushed. And that's why we're concerned about our brainstem. Once our brainstem gets crushed due to all that increased swelling, these patients will no longer be able to breathe on their own, okay? Because that's that respiratory control center. So a couple things you just need to know. Our goal ICP is about 10 to 15, okay? That is how much pressure is being exerted on the ventricles of my brain from being by the skull, okay? Cerebral perfusion pressure, this tells me, am I getting blood flow to my brain? My brain needs oxygen just like everything else needs oxygen. And our goal for our CPP is about 8 to 12, okay? I want you to understand that there's an inverse relationship between the two. As my brain swells, the perfusion drops, okay? So if my ICP is elevated, my CPP is going to go down because the more swelling, the less room for blood flow and oxygen to get to my brain, okay? The big thing we do for kind of determining damage and increased ICP is a Glasgow coma scale. So I would just review your GCS, how to rate them, and remember, no one will ever have a GCS of 0, okay? If they're on the bottom of the pyramid, it's still a 1. So the minimum you can get is a 3. So yeah, just review your Glasgow coma scale. Very much so. So what happens with my ICP? As it increases, my CPP decreases. This is why if I have an elevated ICP, my brain is not being adequately perfused, okay? And this is when we see that Cushing's triad, that systolic hypertension, that widened pulse pressure, and that bradycardia. Well, what is widened pulse pressure? The difference between my top and my bottom. If my top is 200, and my bottom number is 70, that's a very wide pulse pressure. It's much different if my blood pressure was 200, my systolic was 200, and my diastolic was maybe 130. That's not a wide pulse pressure. That's what we mean by Cushing's, okay? So again, really reviewing your ICP and your CPP. How do you calculate your CPP? You take your MAP and you subtract it from your ICP. So what are we going to do for increased intracranial pressure? Remember, TBIs, brain injuries, meningitis, chronic traumatic encephalopathy, all of it can cause increased ICP. So what are we going to do? We can treat the increased ICP as best we can. Drug of choice is mannitol. This is an osmotic diuretic that loves to work on the brain to help pull extra fluid from the brain and get it out. Loop diuretics help as well, but mainly these patients will also probably have an EVD or a bolt in their head that was in the picture to monitor their ICP. So as nurses, it's super important we maintain their MAP and we maintain their systolic blood pressure between 100 and 160. Remember what I talked about earlier with kind of above that 150 to maintain good brain oxygen, all that stuff? Same concept, okay? Elevating their head of the bed is essential. This is going to help decrease in swelling as well. So now we're going to talk about migraines. There's nothing too special about migraines, but we are going to review some medications and some aspect of patient-centered care. Okay. A lot of information on this slide about migraines. I would just really know that these patients can have auras. They might feel like this is coming on, and just are really common across the board signs and symptoms are going to be that photophobia, nausea, vomiting, and pain. So what can we do? We can give them NSAIDs, sumatriptan, etc. But mainly, I would focus my attention on your nursing interventions. Cool, quiet room. Don't disrupt them 15 times trying to get vitals and an Acute and this and that and this and that. Help manage their pain and really just keep them calm. That's going to be our main focus for migraines. So now seizures and epilepsy. What's the difference between seizures and epilepsy? The main focus of this part is going to be, what's the nursing care? If my patient is having a seizure, what in the world do I do? Do I run? Do I scream? Do I hide? Do I call the ambulance? No, I'm the hospital. But anyway, what do I do? I don't really know. What do I do? And some medication considerations. So, seizures, this can happen to just about anyone. And there's just a different abnormal change in just the electricity in my brain, okay? Lots of different types. I don't recommend memorizing all of them. Our tonic-clonic grand mal is our most common. That's when these patients become stiff, contracted, and then very loose, then stiff, all that stuff. That's your traditional seizure, if you will. Epilepsy, though, this is when someone's having frequent seizures that we don't really know what the cause is. And this is a chronic condition, okay? And finally, status epilepticus. This is when my seizure lasts more than 5 minutes. This is an absolute medical emergency because when a patient is having a seizure, they are losing a lot of oxygen because it's a very taxing and, complex process that's happening. So if my patient has been seizing for longer than 5 minutes, I'm concerned that they're going to run out of oxygen pretty soon, okay? That can then lead to arrhythmias and acidosis. So yeah, a lot of our drugs for epilepsy, which we'll review, they do require frequent blood levels. We need to monitor liver function tests, etc., just because they are pretty intense drugs. So during an emergency, we can push lorazepam and diazepam if the seizure has been going on for more than 5 minutes. Our carbendazine, Depakote, and our phenytoin, they're all good anti-epileptics. I would just really know that overall, all these drugs make our patients drowsy. They cause CNS depression. We need to do some good oral care and monitor our bone marrow and LFTs because that's just the type of drugs that anti-epileptics are. Okay. Now, nursing interventions. You're on the floor and your patient has a seizure. Well, they should have been on seizure precautions if you know that they had meningitis, if they had a brain injury, any sort of head trauma history. These patients will probably already be on seizure precautions. That is when the side rails are all padded, there's suction at the bedside, etc. So when a seizure occurs, we need to note the time so we can kind of track the duration. We always turn the patient on their side to prevent aspiration. Okay, that's our airway intervention. So turn them on their side to help them keep their airway and just let the seizure run its course. After the seizure, we want to put an oxygen mask on these patients and we want to check their blood glucose level because these patients might need some sort of oral antidiabetic or insulin because, again, this is such a metabolically taxing process that these patients might be hyperglycemic or hypoglycemic simply just from how much energy is being taken up. So really administer oxygen and check their blood glucose after the seizure. That was something I never really knew that people did after a seizure, but you check your blood sugar, okay? Because again, metabolically taxing, physically taxing process. Okay. And just review your patient education. So I have a practice question for you guys. This is another one of those new NGN style questions, which you will be getting on these exams a bit more frequently. Your professor will start you out with maybe 2 or 3 NGN questions, and as the exams progress, you will get some more exposure. So this is one of my favorite types to work with you. This is our indicated, contraindicated, or non-essential. Okay, so indicated means, yes, we need to do this. We should do this. Contraindicated means, no, we should not be doing this. This could harm my patient. And non-essential means, it's not going to make a difference. It's not necessary. We could or we couldn't, or it's just not pertinent to really what's happening. So I want you to think indicated, absolute yes. Contraindicated, absolutely not. And non-essential, kind of that, not really related. So 52-year-old female client has an open supratenorial craniotomy to remove a malignant brain tumor. The nurse plans post-operative care for the client. Are these actions indicated, contraindicated, or non-essential? So for the first one, is it I, is it C, or is it N? Very good, very good. What about number 2? Yeah, we want our Fowler's position. We want head of the bed up to 30. Okay. What about number 2? What do we think about that fun one? I, C, or N? What are we thinking about that one? Yep, good job, guys. This one is indicated. Awesome. What do we think about the third one? Check the surgical dressing for signs of excessive drainage. Absolutely, it's indicated. Very good job. What about monitor the client for signs and symptoms of increasing intracranial pressure? Absolutely. Great job, guys. Should we assess the client frequently using the National Institutes of Health Stroke Scale? What do we think about this one? It's okay, Ray. It's all good. Yes, we want to use the Glasgow Coma scale. But the answer to this one is actually non-essential. The health stroke scale, it's not too pertinent to this situation at this moment. And I have the rationales kind of in a bit. But when we say non-essential, it really doesn't make a difference at this point in time right now. What about maintaining sequential compression devices? Those are your SCDs. SCDs. Yep, this is indicated. This patient just had a craniotomy and they're going to be bed bound. We usually do these for patients that are going to be immobile for a little bit. The NIHSS is just not appropriate for this specific client. The NIHSS also measures your risk for having a stroke. It's not what we use to assess if a patient is currently having a stroke. It's, well, based on if you answered yes or no to the following questions, it helps us determine, are you at risk for a stroke? So that's why it's not pertinent to this patient. Does that make sense? Awesome job. Very good job, guys. You did very, very well. Super proud. Super proud. So this one is pretty heavy on increased ICP, and Miss Drew might have touched on a few of the topics. You might not have already gotten there yet if you haven't discussed SIADH or anything like that, but I do want to kind of talk a little bit about this. So again, this is the same patient we had. This is how case studies go. And that's why I chose this, is that you'll have one slide and then the next slide, NGN likes to do case studies. So this is what we would call a case study. So what are some potential post-op complications of removing a brain tumor? And what would our assessment finding be? So what do you guys think about the post-op complication of DI? Remember, that's our dry inside. Absolutely. We know that when we take out a piece of the brain or a tumor, we could be potentially taking out, like, whether it be a pineal gland or any sort of gland. So absolutely, if a patient had a craniotomy and they had portions taken out, they're at risk for DI. What would we see for a DVT? What would we see for a DVT? Good job. Great job. What about hypokalemia? Awesome. Love the application. Great job. What about syndrome of inappropriate ADH? So SIADH, that's our opposite of DI. So what do you think we're going to see then? We'll talk about that one. We will talk about that one. And what do we think about increased intracranial pressure? Absolutely. Great job, guys. Great job. So you were right. For SIADH, we're going to see decreased urinary output. Okay. So you guys got all of them right. Okay. So now I have another question for you guys. A client is admitted to the hospital with a diagnosis of seizures. The nurse should prioritize which of the following actions. So this is a prioritization question. Awesome job, guys. Whenever we're talking about prioritization questions, it's always airway, breathing, circulation. So while all of these are correct, while A is correct, while B is correct, and C is correct, they're all correct. This is your what's the most correct. And when you ever see the word prioritize, airway, breathing, circulation, airway. We have to make sure the airway is clear during the seizure. Yes, we want seizure precautions. Yes, we want anticonvulsants. Yes, we want to tell someone. But when we're talking about prioritization, you follow the airway, breathing, circulation. Number D addresses the airway. Okay. So yes, A is a good thing to do, but we want to keep the client's airway open. This is worded weird. They aren't having a seizure, though, just diagnosed, a diagnosis of them in the past. So with a diagnosis of seizures, that means that they've been admitted to the hospital and this is what they're diagnosed with at this moment. I know it's worded a little bit weird, but it says they're admitted to the hospital with a diagnosis of seizures. That's kind of what they came in with. That's what our admitting diagnosis is at this moment. This is also like a critical care course, so a lot of this is going to be set in like an ED. You have a patient coming into the ED with a diagnosis of seizures. They're having a seizure. So I apologize for it being a little bit worded. I'll try to find some practice ones that are a little bit clearer in the wording in the future. But like if you ever see prioritize, airway, breathing, circulation. I have another prioritization question. Client is, yep, ABCs. ABCs. A client is admitted to the hospital with a diagnosis of increased ICP. The nurse should prioritize which of the following actions. Awesome job, guys. This one is going to be, well, that's okay. This one is actually A, okay? But I like the thought process we're going. Remember, when we're prioritizing, we do the airway, breathing, circulation, but what do we always also do first? What do we do first? We assess our patient. Which one of these talks about assessment? Yep, A is going to be our assessment question. So we need to monitor the vital signs. This question's also kind of trying to get us thinking of how do we know someone's experiencing ICP? That's that Cushing's triad. How do we know if they have Cushing's triad? Ray, do you have a question?
Yeah, but I can ask it after you're done.
Okay, got it. So Cushing's triad, we get that from vitals. So this question we assess first. Absolutely, mannitol is great. Elevating the head of the bed is great, but vitals also help us determine your airway, breathing, circulation. My heart rate, respiratory rate, all of that plays into those ABCs. Those are your vitals. Does that make sense? Everything else is great options. We do want to do that, but we always assess first, and A also goes into that airway, breathing, circulation, because that's what our vitals are about. Okay? Ray, you can ask now.
Yeah, thank you. Now that you explain it more with assessment, I see the importance of assessment. I remember Miss Stroop mentioned that like when it comes to like approaching her questions, like she's like, oh, like which one is gonna be like the one that solves the underlying problem. So
Mm-hmm.
that's why I picked B, because because it says that there's already a diagnosis of increased ICP. That was
Yeah.
like, I was
Mm-hmm.
like, oh well, this is gonna treat the underlying problem, but so you're saying that before we treat the underlying problem, we should always assess, correct?
Yeah, because also, if my patient's showing signs and symptoms of increased ICP, I'm going to give them mannitol. Okay, mannitol is going to help get the fluid off and hopefully help that Cushing's triad stabilize. But if I don't check my vitals before I give mannitol, how do I know if the mannitol's been affected if I have nothing to compare it to?
That makes sense. Thank you so much.
No problem. And like Miss Droop does ask a lot of questions where it's like, what's going to help? And that's what she does. But remember, at the root of it, all of her questions are ATI styled, NCLEX style questions. And NCLEX really hits on prioritization, delegation, things like that. Now, if none of these said, like if there was no monitor vital signs, then we would want to do kind of a reassessment of the answer choices. But absolutely, you do need to get those vitals first. You need to kind of, if you ever see assess, it's kind of like that's the answer, if that makes sense. As long as it's like assess appropriately, not like, oh, assess for depression. Like, no, that has nothing to do with increased ICP right now. But yeah, you do need to monitor the vital signs frequently. That's just our priority right now. Okay, because the mannitol might take a little bit of time to work. What if I'm having a hypertensive crisis? I'm going to need to know that because I'll hold off on the mannitol because at this moment I need to push antihypertensives. But yeah, you guys, I love the thought process. I love kind of connecting. Well, obviously, mannitol is going to help the underlying condition. Elevating the head of the bed is also going to help with the symptoms. So, again, all these are correct. But when we're talking about prioritizing, you see in the question it says prioritize. That's what these questions want to pull from you. So now we're going to talk about disorders of the eye and ear. For glaucoma, we're going to define IOP and really just talk about medications we give and what we avoid. So it's not really pertinent to know a lot about like glaucoma, causes, primary, etc. We just know that if someone is having an angle closure glaucoma, this is a medical emergency because now I have an outflow obstruction in my eye, which can lead to permanent blindness because I'm going to have all that fluid in my eye build and build and build and build and build. And we don't want to know what happens when that occurs. It's not pretty. It's not fun. Okay. The concept of IOP is just our ocular pressure. Okay. Our intraocular pressure is maintained by a balance of inflow and outflow. But with angle closure glaucoma, I have no more balance of outflow because it's closed, it's stuck. And I'm just gonna have pressure build up in my eye, and it's not fun at all. So what do we need to do? We need to reduce our intraocular pressure, usually by surgery with a shunt. We do not want to dilate the eyes. Okay, so just remember that. Do not dilate. Okay. Retinal detachments are also very common, usually treated pretty well with surgery. Lots of different types of retinal detachments, but just know a lot of the risk factors are going to be diabetic retinopathy because of the eyes, aging, even farsighted individuals due to the excess strain on the eye. But regardless of the cause, a lot of them have the same signs and symptoms of those flashing lights, floaters, loss of vision, etc. Okay. Um, this is a medical emergency because the retina actually separates. And again, not pretty, not fun. But it can be treated pretty well with surgery. So I would just review your pre-op versus your post-op. Pre-op, we really want to minimize movement. We can get an eye patch, maybe some topical drugs to help like avoid my pupil from kind of going in and out and in and out. We want to keep the eye stress-free. Um, Sorry, people are just driving super fast down 42. Um, and post-op, we really want to assess for drainage, report pain and nausea, etc. A lot of our focus is going to be patient education if they've just had an eye procedure. We want to keep our eye in the proper position. Do not lie on your back. Keep your head elevated. Don't go on an airplane. We don't want to be messing with that. Now's not the time to be doing yoga. Now's not the time to be doing cartwheels. Really, rest and recovery is super important. Mastitis, this also kind of goes hand in hand with another disease process, which we'll discuss, and we'll talk about some treatment and some complications. So this is almost often preceded by progressive otitis media, which is just infection. Big, nasty ear infection in the middle of our ear, okay? Why are we concerned? Eardrum perforation. So these patients, you'll actually see lots of swelling behind the ear, lots of pain. Their eardrum just looks red and irritated. But we're really, really concerned if this infection progresses to the brain. There can be a brain abscess, possible meningitis, which is that like infection of the meninges, and unfortunately death. So what are we going to do? Antibiotics is very good, but we have to review our antibiotic protocol. So number one, before we get any antibiotics, we have to get a culture and sensitivity. So you get that CNS, you send it to the lab. Then you can start them on broad spectrum antibiotics because it will take a little bit of time to, get the results back, which is totally normal. But if we do the CNS after we've started antibiotics, that can actually mess up the results. Okay, so always get the CNS first. And what was our major complication? Brain infection, brain abscess, all of that. So monitor for neurological changes as well. Meniere's disease, I want us to focus on fall risk. Why is this patient a fall risk? We're also going to talk about attacks and some nutrient considerations. So with Meniere's disease, our ears are like our balance center. We balance through our ears, if that makes sense. It just helps us maintain our equilibrium. But what happens, we have just an excessive amount of fluid and we don't really know what the cause is. But what we do know is all this fluid is building up in my ear. And now I have really, really bad vertigo because I can't balance anymore because I've got so much fluid in my ear. So these patients, what's specific about Meniere's disease as opposed to just like an ear infection or swimmer's ear is that they'll actually have attacks, which leaves them incapacitated, faint, unconscious, etc. And if they're having repeated attacks, these patients are actually getting worse and their prognosis is also getting worse. So this is a really big safety concern because we don't want these patients. What happens if you get incapacitated while you're on the road? It's a major, major, major safety concern. So what are we going to do for these patients? We can give them some diuretics. Diazepam also helps kind of just relax everything, kind of help prevent those attacks. Surgery is very common. So as nurses, these patients are a fall risk. We want to minimize their vertigo. Maybe having them walk a couple laps around the unit might be a bit much for them. So maybe just up to chair, making sure that they're a two-person assist, etc. Some things that we can teach them to do is really restricting some of these things, specifically sodium. Sodium is not very good for holding on to water, and some other different reasons. But yeah, just give your patient some helpful tips. Acoustic neuroma. Really, I just want you guys to know what is the function of cranial nerve 3 and what can we do to help our patients kind of have optimal function. So there's a tumor on cranial nerve 8. I believe that's 8, 5, 6, 7, 8. Yes, it is. This is responsible for hearing and balance. Why are we concerned? Again, balance, fall risk, but as the tumor grows, it can also damage some other cranial nerves. And usually a suboccipital craniotomy is how we're going to treat this, okay? But unfortunately, once hearing loss is achieved, you're probably not going to get it back. A word about foreign bodies. Just leave it in. That's really all you need to know about foreign bodies. Does anyone know why I put a Dixie cup on this page? I don't know if you guys have seen that before. Maybe some with some advanced training. That's okay if you haven't. Yep, it's for the eyes. So if a patient has been impaled by the eye, Usually EMTs, paramedics, whoever arrived on site will try to stabilize that, usually by cutting a hole in a Dixie cup or a small cup, just to kind of create a protective little area around it so no one's hitting it, no one's sliding it, etc. If you ever see a foreign body anywhere in the body, specifically eyes and ears, but really anywhere in the body, leave it in. Continue your assessment, but leave it in. That is all. Thank you. Now we get to talk about some fun stuff, respiratory. We talked a lot about COPD and Complex Health 1, but now we're really just going to focus on our exacerbations and some ABGs. So we know it's a combination of chronic bronchitis and emphysema. Great. When someone is having a medical emergency, though, with COPD, they are pretty acidotic and they really do have a loss in oxygen. Their O2 sats. I know we said our nice normal was 88 to 92, but during a really bad exacerbation, they might be at 80, and that's not good. Okay. What are we really concerned with, though? As we have this acidosis occurring, these patients are at risk for cardiac dysrhythmias and even respiratory failure. Drugs of choice, your beta-adrenergic agonists, that's your SABA and your LABA, corticosteroids, mucolytics, etc. But really, we get a CBC and a sputum culture. What I do want you guys to review for COPD is your arterial blood gases. How do we know if compensation is occurring? How do we know if, like, their body's trying to compensate, if the compensation's not working, etc. So most of your COPD stuff is going to be about arterial blood gases. So I would review that. I have a few ABG little study guides posted. I can always send you guys, but I did post some of those as well. But yeah, not too much about that COPD. So now we're going to talk about pneumonia. As nurses, how are we going to prevent this in the hospital, and what major consideration are we concerned about? Pay special attention. I love this photo. It talked about decreased gas exchange, very important, but it also talks about decreased breath sounds. If you are in the hospital and you're assessing your patient and you started at the top, you're doing the Greek key pattern, and as you go down, where did you say we can find the ABG study guides? Totally shameless plug, but I have them up on my Instagram. But I will pop them in your guys' group chat as well. I'm very proud of my cute little notes. But I'll send them, don't worry. You're good. Never apologize for interrupting. Anyone have any questions, pop them in the chat, raise your hand. I'm totally cool with anything. But when we're doing that Greek key pattern, and as we go down the back, if you start hearing diminished breath sounds, that means that there's probably fluid building up, and you might need to be getting a CBC soon, just to look, maybe they are showing signs and symptoms of infection, because that's usually very indicative of pneumonia. Pneumonia is just fluid building up in the lungs. So again, multiple different causes. In the hospital, we're really concerned about this VAP, ventilator-associated pneumonia. This is why we make sure that we're thoroughly cleaning our intubation tools and kits, and that we're assessing if our patient is ready to wean off a ventilator, which we'll talk about later. But we don't want our patients on vents forever, because the longer they stay on the vent, not only is that associated with a reduced incidence of getting off the vent, but also it puts them at so much risk for a couple other complications. So in our assessment, we might hear some rhonchi, some crackles, and just decreased sounds. What are we going to do? We're going to get a chest x-ray, sputum culture, blood culture, the whole 9 yards. What complication are we concerned with? Sepsis. So sepsis is a full body inflammatory response to an infection. We have an infection in our lungs, our patient's at risk for sepsis. Okay, we'll talk a lot about sepsis and septic shock later on in the course. Not pertinent for this exam, but just know that infection, risk for sepsis. And then empyema, this pus can build in the pleural space, which can cause reduced ventilation, which we'll talk about in just a few moments. So what can we do? A lot of it's going to be preventative, giving cough, deep breathing, incentive spirometer. All that's going to help prevent pneumonia. Getting that CBC is also important because we need to know what antibiotics we might need to give. And yeah, just review some of your nursing interventions. Now we're going to talk about influenza. So yeah, we're really going to separate pandemic influenza versus seasonal influenza. So seasonal influenza, this is your influenza A, B, and C. This is very, very contagious, rapid onset of your signs and symptoms. One thing I do want you guys to know, highlight, star, circle, whatever, is that it's diagnosed by symptoms, mainly because there's a really high false negative rate for tests. So really, we diagnose it with our symptoms of that headache, muscle ache, fever, chills, fatigue, etc. Again, complication, pneumonia. What are we going to do? Well, we can give antivirals, but you have to give that within 24 to 48 hours of the onset of your symptoms. So if I was feeling really crappy 3 days ago, might be a little bit too late for some Tamiflu. These patients will be on a droplet precaution. Also review your patient education. Your patient might be asking you, when can I go back to school? When can I go out? Really understanding that if you have the flu, you are contagious up to 1 day before the onset of symptoms and 5 days after the start of your symptoms, okay? Obviously, flu can be prevented with vaccines. When we're talking about pandemic influenza, basic patho, these are not related to human viruses. These patients are at much increased risk for viral pneumonia and ARDS, which we will discuss in a moment. If someone is experiencing ARDS, they're having trouble breathing, new confusion, bluish lips and face, they need to go to the ER, okay? Again, a lot of the treatment is going to be supportive. Again, you can give Tamiflu if it's within that 24 to 48, it should say 48, 24 to 48 hours, etc. What we know is that tummy time is great for COVID. These patients might also need to be ventilated. When you're assessing your patient, you're getting their health history, ask about recent travel as well. I'm going to talk about pulmonary embolism, specifically focusing on labs, signs and symptoms, and coags. Pulmonary embolism usually caused by a DVT. This can cause a loss of perfusion or a decrease in perfusion to the lungs. The severity really depends on where the clot lodges. Lots of signs and symptoms. Hemoptysis is really common. Distended neck veins, hypotension, very, very common. This can lead to hypovolemia and shock, okay? It's a big deal. Lots of things put patients at risk for pulmonary embolism, specifically hip and pelvic fractures, history of AFib, and hormone replacement, whether it be hormone replacement therapy or birth control. Very, very big risk for clots, pulmonary embolism. So, gold standard is a pulmonary angiography. This is going to help us visualize if there's a clot. In the hospital, you'll also frequently see a D-dimer done on patients. If you're on a cardiac floor, they usually do D-dimers on a lot of their patients that have a history of AFib. This lets us know, are there clots somewhere? That's what your D-dimer does. So if your patient has an elevated D-dimer, we're really concerned for clots and thus a pulmonary embolism. What are we going to do for this? Fibrinolytics, you're a LTP, the same considerations when we talked about for stroke, so no active bleeds, etc. We also give them warfarin and heparin, so just really review your therapeutic ratios. So in order for warfarin to be therapeutic, it needs to be between 2 and 3. Heparin, it needs to be between 40 and 70. That means it's great. Also, remember, how long does warfarin take to work? Does it work right away? Does it take a few days? What do you guys think about that? Do you guys remember? Which drug works right away and which drug takes a little bit of time to work? Yep. Warfarin takes about 3 to 5 days to work. So we're going to start them on warfarin, but we do need a little bit of coverage. So we're going to put them on a heparin drip. Absolutely. So heparin drip helps right away while we get them bridged to warfarin. I actually had a patient that ended up going home with their Lovenox shots because they didn't need to be in the hospital anymore, but their warfarin hadn't kicked in. They weren't in the therapeutic range, so we just sent them home with the Lovenox, low molecular weight heparin shots, and they did very well. So it is very common that patients might need to be on heparin a little bit longer. Before starting all anticoagulant therapy, we need to get baseline coagulation panels. This is part of our assessment. Remember your antidotes. So let's say my patient has a INR of 7. Probably going to need to give them some vitamin K because they're not going to clot. And that is very dangerous. Okay. Now we're going to talk about acute respiratory failure. So we're going to split it up in two. What is oxygenation failure and what's ventilatory failure and labs? So acute respiratory failure can be, again, split into two. So if we're having an oxygenation failure, this means that there is an issue with lung perfusion, okay? So what do we mean by that? We're going to have a low PaO2, okay? So this is just simply, I'm having a hard time getting in oxygen. If I can't take in oxygen, I cannot take it down to the alveoli and swap that CO2 for O2. I'm having an oxygenation problem, okay? If I'm having a ventilatory problem, this means that I'm having a very hard time simply with, think physical, lung, chest wall, okay? I'm having a hard time breathing out, okay? I'm having a very hard time breathing out, okay? So that's how they kind of split them both into two. So really, really just review that. Review how we differentiate oxygenation failure versus ventilatory failure. If my patient has a severe head injury and they are having difficulty in initiating their own breaths, do you think that would be oxygenation failure or ventilatory failure? If I have a TBI and it's messing with my autonomic nervous system, do we think that's ventilatory or oxygenation? Absolutely, it's ventilatory. I'm not initiating those breaths. If I had a swimmer that was at the bottom of the pool, do you think that they had ventilatory failure, oxygenation failure, or even both? Probably both. But that's going to be more of our oxygenation, where I don't really have an issue with taking those breaths in and out. I just don't have oxygen available. And that's why we see these differences in the labs, where if I'm having an oxygenation failure, I'm going to have a PaO2 of less than 60. If I'm having ventilatory failure, I'm going to have a high pH because I'm holding on to CO2. That's a respiratory acidosis. Okay? But no matter what, you're always going to be hypoxemic. Remember, your PaO2s are not the same as your oxygen saturation. Okay? So yeah. What can we do? We can do end-tidal CO2 monitoring for ventilatory failure, etc.
Hey Tiffany, real quick, I'm sorry to interrupt.
No, go for it.
Could you briefly explain the difference between the PaO2 and the SpO2 for me, please?
Okay. Yeah. Absolutely. So it really just boils down to like lab values and really where it's coming from. PaO2, that's our partial pressure of oxygen. And this one is usually, we want it in a nice, like, sweet spot of like 70 to 80, above 75. But it's just kind of arterial blood. So it's not really like venous, if that makes sense. Um, our O2 sats, kind of what we put on like the patient's finger in the hospital, that is more of our venous blood, if that makes sense. Yeah, no problem. It's just one is measuring arterial, the other is venous, and they just have different normals, okay? So if you see like PaO2 of 80, they're fine. They're fine. I don't want you to think that like they're what I'm trying to say is PaO2 and O2 are not the same, okay? If I have a PaO2 of 80, I'm great. I'm fantastic. I'm having a wonderful time. If I have an SaO2, which is your pulse ox of 80, I'm not having a fun time. So they are a little bit different. But just think above 60 is good for PaO2. It's great. Okay. So if they're having oxygenation failure, we have to treat the underlying cause. What's going on? In the meantime, we give them supplemental oxygen. If they're having ventilatory failure, they're probably going to need to be put on a ventilator because they're not doing that on their own. Okay? But no matter what, we always have to treat the underlying cause. If fluid overload is causing the vent or oxygenation failure, I need to get the fluid off. Okay, so treat the underlying cause. SpO2 is a lot better to monitor because we can get that from like a pulse ox. We can't necessarily get that from something that's non-invasive, if that makes sense. In the ICU, the things are much more developed, so you might be able to get that off of a central line situation, but don't worry too much about it. And always remember, acute respiratory failure is a complication of another medical condition, so we have to treat the underlying cause. If we don't treat the underlying cause, now we have ARDS, okay? So I want you guys to think about this. With ARDS, would putting them on a 100% non-rebreather work in this case? What are some vital sign changes? So before I begin, do you guys think if my patient has ARDS and their O2 sats, their SaO2, their pulse ox is 85, should I get a non-rebreather on them? What do we think? What are we thinking? Would a non-rebreather be cool? That's like the most powerful. What do we think? You can just give me a thumbs up for yes, thumbs down for no, question mark if you don't know. It's totally okay. Totally okay. What do we think?
I want to say no,
You're correct.
because even if we're giving them oxygen, that's not the problem. It's more so how the body is using the oxygen. Am I along the right line?
Yep, you're on the right track, and we'll reinforce that. But the correct answer is no. Supplemental oxygen is not going to work because if we take a peek at inside my lungs, we find the alveoli. That is the site of gas exchange. Usually they're empty. This allows them to take in oxygen and release CO2. But what happens if my little tiny alveoli get filled with fluid and pus? I have no more room for gas exchange. So I can give them all the oxygen they want. My little alveoli are filled with so much gunk and yuckiness that there physically is no more room left to initiate gas exchange. I no longer have a site for gas exchange because my little alveoli are full with stuff they shouldn't be full with. So that's why they have what is called refractory hypoxemia, meaning if I give them 100% oxygen, their SATs will not improve. Okay? There's no longer any room left for gas exchange. Usually in response to an inflammatory process, if someone had like pneumonia, it triggered an inflammatory process, cytokine storm released a bunch of yucky particles that get stuck in my alveoli. Just want you guys to know that ARDS is very common in sepsis, burns, COVID, pulmonary embolism, etc. There's an injury to my membrane that is the site of gas exchange, okay? That thick, yucky stuff, that's stopping gas exchange from occurring. Okay, does that make sense? Why I can't give them oxygen? Oxygen's not going to help. Do you guys kind of understand why it's just not going to help? Give thumbs up, thumbs down. Saw a few thumbs up, so good. That's really what I want you guys to know for ARDS is oxygen's not going to work for these patients. Specifically, it's got a very high mortality rate, as you can assume why. That's why you'll kind of see this ground glass on the x-ray. All their O2 sats are going to be pretty low. And yeah, you're going to see lots of difficulty breathing. They're going to have increased work of breathing because they're trying so hard to take in more oxygen, but it's not going to work because my alveoli can't do their job because they're filled with gunk. Okay, so that's why you'll start to see that tachycardia and that drop in blood pressure. Okay, so what do? We PEEP them, okay? They're going to need to be intubated and we give them PEEP. This is going to help pop. So PEEP pops. PEEP's going to help pop open the little alveoli, give them extra room to do their thing, and we're also going to be giving them antibiotics to work through that. Fluid management, because remember, their lungs are kind of filled with fluid management, etc. On the left, I listed some of the phases of ARDS. This kind of helps put everything into perspective. But when we're in that like first phase, that's really, we need to treat the underlying cause because they're kind of going in a bad direction. That's when you'll start to see some of this restlessness, crackles, cough, etc. When we're kind of in that fibrosing phase, now I'm going to have some pulmonary hypertension. Now I'm having some issues with gas exchange. So now we're going to maybe see that in an ABG. They might be showing signs and symptoms of MODS, multiple organ dysfunction syndrome. So really watch your kidneys. And then there's the resolution phase. So not everyone really makes it to the resolution phase. Some might stop at the exudative phase and we treated it and it's great. But as the worse they get, you have less and less time to correct the underlying cause, okay? And this resolution phase, they're either going to get better and have severe lifelong complications, or they're going to pass away, okay? So, finally, we have our chest trauma. Really, chest trauma, I just want you to focus. What was the mechanism of injury? Okay, where did this injury occur? Is there potential damage to my lungs, etc.? And some assessment stuff. So when we have pulmonary contusion, whenever you think contusion, that's just brain. That's sorry, not brain. That's just bruise. Okay. These patients will usually have some bloody sputum, decreased breath sounds, crackles, wheezes, etc. Rib fractures are also very, very common. But again, that's why we need an x-ray. How many ribs are fractured? And that's important on the next slide. Most resolve on their own, but really teach them how to like splint if they have to cough, etc. Because our number one concern with lots of chest trauma is these patients will like, it's going to hurt to take a deep breath in and out. But if they're not taking full deep breaths in and out, they're at risk for pneumonia. So see how everything kind of likes to play together a little bit. Flail chest, this is what I talked about with, are there two ribs right next to each other? that are fractured. If there is, this person is at risk for flail chest. Well, you'll actually start to see paradoxical chest movement. So instead of them rising and falling like normal, one might rise and the other might like just not be on the same page, and it's not good. So with these patients, highlight star that their mediastinum will deviate toward the opposite lung during inspiration. Okay. Tension pneumothorax, this is another collapsed lung. We'll also see a mediastinal shift. And really, the treatment is going to be a chest tube or a needle to open it up, get all that trapped air out. Pneumothorax, air enters the chest and causes lung to collapse, but we won't see a shift. And then finally, hemothorax, that's just blood building in the pleural space. Remember, as anything builds in that pleural space, that just leaves less room for the lungs to fully expand and contract. Okay, so I have a few practice questions. So a 60-year-old male client developed severe hypoxemia and skeletal muscle weakness following a viral infection. He was diagnosed with Guillain-Barré and was intubated. He's been mechanically ventilated for a week and will be intubated and ventilated for at least another week. So, do we think these actions are indicated, contraindicated, or non-essential? So this kind of covers your advanced airway portion of your review. So for number 1, do we think that for these patients, we should maintain the head of the bed elevated at least 30 degrees? For a patient that is being mechanically ventilated, what do we think? Yep, this one is indicated, especially when they're on that VAP. It's quite indicated. Okay. What about limiting visitors to once per day? And you guys are taking psych right now, so I want you to think about the psychological considerations. Do you think limiting visitors would be helpful, harmful, or non-essential? What do we think about that? Because your next gen NCLEX likes to tie a lot of things together. Absolutely, it's contraindicated. Okay, especially when patients are in a bit more critical condition. We want to encourage family to stop by. So limiting visitors is quite unnecessary and could really have a bad effect on the family. Okay. What about using commercial tube holders rather than twiddle ties to keep the endotracheal tube in the proper position? What do we think about that one? It's okay if you don't know. What is your gut telling you about that one? So this one's actually non-essential. It really makes no difference what type of ties I hold it together. It's really just non-essential. Good job. What about performing meticulous oral care every 12 hours with a suction toothbrush and antimicrobial rinse? What do we think about that? Absolutely, it's totally appropriate. We do want to prevent that VAP. So very good. What about wearing a mask when providing care to the client? Is it really only 12 hours? Oral care is every 12 hours, usually done in the morning and at night. What you might be thinking of is like trach care. That's done a bit more frequently, and suctioning is as needed. Okay.
I had a nurse that was performing oral care on a patient who was on a ventilator every hour. I wonder why she was doing that.
Um, I'm not entirely sure why she might have been doing that. I know that I have no idea what it's actually called, but some patients kind of when they're not doing very well on the vent, they have really, really bad breath because there's like a lot of acid and stuff building up. So that might have been the reason. You can really do it like as many times as you want, but like you should be doing it at least every 12 hours.
Okay, so the standard is 12 hours. Got it.
Yeah.
Thank you.
No problem. No problem. Yep. And that's just like more like teeth brushing, if that makes sense. What about so wearing a mask when providing care to the client? I think that was the last one we were on. So I see a couple of you saying wearing a mask is indicated. Can someone talk me through the process of that?
Do you want to make sure, like, sorry, I just popped up. Don't you just want to make sure that like you're not spreading like infection to these patients? Maybe
Yeah.
like safety wise.
Mm-hmm. So I totally get your thought process, and things are a little bit different now, like with COVID, and that became kind of the norm. But this patient is not in a active infection. You as a nurse just don't have an infection. So this one's actually non-essential. It makes no difference whether or not you wear a mask around this client when you're just kind of providing any sort of care to them. We do wear like masks and stuff for some like trach procedures, things like that. But just like if I'm popping into like vitals or anything like that, it's non-essential for this patient. A little bit tricky, but that kind of hits on your precautions. And this patient would just be standard precautions where you just hand hygiene, washing hands, etc. What about administering prescribed ulcer prophylaxis? Absolutely. Patients on ventilators are at increased risk for ulcers. Okay. What about performing deep endotracheal suctioning every 2 hours? What do we think about that one? It is contraindicated. It is contraindicated because you suction as needed. So if you take anything from trach care today, you suction as needed. And that's a big, big NCLEX question. You suction as needed, okay? You wait a few minutes in between passes and you don't put it in for more than 10 seconds, okay? Because you're essentially obstructing the airway. But great job. It's as needed. Very good. What about performing a complete bed bath on this client daily? What do we think about giving them a bed bath every day? Yep, it's non-essential. we do that to almost all of our patients, okay? It's not pertinent to this question. This question is asking us for preventing ventilator-associated pneumonia. Does bed bath have anything to do, good or bad, with it? Nope. Yeah, we do that to all our patients. It's non-essential to this question. It doesn't make a difference. Very good. And last one, should we be collaborating with an RT to perform chest physiotherapy every shift? Absolutely. Chest physiotherapy really does help us to loosen up some secretions that might be in there. The longer secretions stay in there, you're at risk for pneumonia and all of that stuff. So very good job, guys. We did very, very, very well. So now I'm going to have a bit of a talk about some critical care considerations. I did forget to include a EOL kind of consideration, but as nurses, it is not our place to talk about organ donation or anything of the sorts. We simply want to provide like education towards our patient, but if there's any topic of organ donation, we're not the ones to initiate any of that. It's very common with your spinal cord injuries, but really we don't initiate that conversation, okay? We're going to talk about our advanced airways, specifically our ET tubes. No matter what, we always assess the patient first, and then we assess the ventilator. Whether the ventilator is beeping, alarms are going off, it's yelling at you, great, we're going to assess that, but we look at our patient first. Do they look blue in the face? Do they seem in any discomfort, any distress, etc.? So, after a patient has been intubated, our goals for assessments, we want to be very, very cognizant of auscultations. And then remember, when we put our hands together and when there was symmetrical chest wall movement, they went out at like an equal, space. That's what our assessment's going to be. So we want to make sure that there's bilateral breath sounds and symmetrical chest movement. So when we're preparing to intubate, if we can, we're going to explain the procedure, monitor vitals. We always hyperoxygenate before intubation. Okay, if our patient is, we're ambu bagging them, etc., we want to hyperoxygenate before we go. Intubation should take less than 30 seconds to prevent hypoxemia. Okay, that's why we hyperoxygenate before. We also want to provide sedation and IV meds and paralytics because, again, once that tube goes in, we want the tube doing the work. We don't want our lungs to do the work. But we have to coordinate with the provider who should be at the head of the bed, like intubating. I'm about to push this paralytic in. You need to have this in because I'm paralyzing their lungs essentially, okay? Soft restraints help with these patients just to prevent unplanned extubations in the clinical setting. Positioning, tube should be about 2 to 3 centimeters above the carina. Really, we suction the tube, and whenever we suction, should be less than 15 seconds, okay? Verifying placement, chest x-ray is very important, but we can also assess breath sounds, assess movement, and look at the measurement markers. At the end of the tube, there should be a marker. If it was at 5 and I come back to my shift and now it's at 7, I know something moved, and I'm probably going to need a new x-ray, probably need to tell the provider, etc. As an RN, though, we have to make sure that we have respiratory therapy available, and we really want to assess their level of sedation, which with the Richmond scale, because we don't want them being overly sedated, but we want them sedated enough to be comfortable, okay? Propofol and a fentanyl drip are drugs of choice, okay? And as always, monitor for complications of pneumonia, infection, and damage. So, ventilator settings. I always found ventilators to be a little bit difficult to understand, so let's break it down. So when we're talking about the FiO2, this is how much oxygen is being given, okay? Just remember, room air is at 21, so usually this ventilator will be obviously above 21. But just know the closer you are to 100, that means that you're requiring more oxygen. If you're requiring more oxygen, you're probably a little bit sicker, okay? Tidal volume, this is quantity. How much gas is being delivered in one cycle? A smaller patient, that is a child, will probably have a smaller tidal volume than compared to a 6'5" sumo wrestler, just to kind of put that in perspective. Rate is the minimal amount of breaths per minute should be between 12 and 20. If you're having PAP, this helps us really measure the pressure of the ventilator. If there's any issue in lung compliance, like with pneumonia, this alarm's probably going to sound. Like we talked about PEEP, PEEP was very, very good for ARDS. A high pressure limit refers to a pop-off mechanism that allows the ventilator not to exceed the pressure limit to avoid barotrauma. So let's say something goes wrong and now I have an increased amount of pressure going into my lungs. This limit will cap the amount of pressure so that pressure doesn't continue to increase inside that chest cavity. No good, okay? And sensitivity, this is how much pressure a patient must generate before they deliver a breath, before the ventilator delivers a breath for them, okay? Finally, modes of ventilation, assist control. This matches the patient's effort. It is a full support mode, but it helps if the patient's effort is there, it matches. So if my goal is 500 and the patient gets 200, they will receive 300 to get that 500. Your SIMV, this allows for independent spontaneous breaths. This is what we use when we're trying to wean our patient from the ventilator. Pressure support, this is great for patients that can breathe on their own. It just helps them take it better. And the non-invasive, those are our CPAPs and our BiPAPs. And that is all I have for you guys. Does anyone have any questions?